All right, we might start now. Good evening and welcome, everyone. For those of you who do not know me, my name is Namita and I am the GP Liaison Officer at Ramsay Clinics, Macarthur and Wentworthville. I am beyond delighted to introduce this much anticipated quick log GP education webinar, Unpacking Anxiety, a GP's Guide to Managing Anxiety Disorders, OCD and Panic Attacks. This special interest series presentation has been put together by our newest VMO, Dr. Shivdev Sandhu, who is based at Ramsay Clinic, Wentworthville. There will be a 30-minute Q&A session up until 7:30 p.m. at the end. Should you have any questions throughout the presentation, please pop it in the Q&A box and we will endeavour to answer as many as possible at the end. Please be advised that this session is recorded and will be available to review afterwards. Aside from this, without further ado, I will now hand over to Dr. Sandhu.
Thank you, Namita, for those kind introductions. A very good evening to everyone. Today's presentation is a guide on the assessment. Basically, we are unpacking anxiety, a general guide towards the assessment and management of anxiety disorders. I'll be specifically looking at generalized anxiety, panic disorders, and OCD. Anxiety itself is a highly prevalent sort of symptom, and in anxiety disorders, they are very highly prevalent conditions. The current rate of diagnosis of anxiety disorders in Australia, as per the recent Bureau of Statistics, from 2020 to 2022, more than 1 in 6 Australians, that's about 17% or 3.4 million people, aged 16 to 85 years of age, had a 12-month history of anxiety disorders. That's a very staggering sort of number, which suggests it's a very highly sort of prevalent morbid sort of condition. Women are more likely than men to have a 12-month history of anxiety disorders, almost double its percentages. And what does that sort of say to us? That suggests to me that it's a very highly prevalent condition. It requires a lot of tailoring in regards of your assessment and ensuring that you be able to reach a certain diagnosis, which can then tailor your management plan accordingly. It's also got a very highly overlapping symptom profile. A recent study found that the DSM-5 features hundreds of diagnoses comprising a multitude of symptoms. There is considerable in the symptoms among diagnoses. They found that about almost 630 distinct psychiatric symptoms and over 290 of them overlap between conditions. When there's such a highly overlapping symptom profile, it suggests that it's difficult to sort of disentangle, distinguish between conditions. Have a look at this table here. Anxiety itself is found in almost 12 diagnoses as per this table. Insomnia, irritability in mood, appetite changes, restlessness, these can all form part of an anxiety disorder as well. And I think it suggests to us that given how prominent and prevalent this condition is and how wide its symptom profile is, it's important that we tailor a good history and an assessment process so that we can come up with the right form of management. The learning objectives that I'm hoping we could cover today is, as mentioned, anxiety disorders are very prevalent and they are fairly enduring. There are a number of different anxiety disorders. For the purpose of today's presentation, I'll be focusing on generalized anxiety disorders, panic attacks and panic disorders, being able to identify some of the key diagnostic features in OCD. What are those salient features that you should go through in a history taking, in a mental state examination, so that we could tailor our management accordingly? And it's important to also then look at what we're going to look at. It is the pharmacological treatment options for anxiety disorders, focusing on those 3 conditions. So as GPs, you would often come in contact with patients presenting with symptoms of anxiety. I want you to remember that firstly, it's a normal physiological response when someone has anxiety. Everyone goes through anxiety in our lives, but it's important to recognize when it becomes a pathology. Are they recurrent? Are they fairly prevalent? Are they impacting their functioning or their overall capacity to manage day-to-day activities? Do they have episodes that are affecting their relationships, their employment? These are things that need to be explored. And a comprehensive history is what's required to distinguish them. And that includes a mental state examination. I think in the history sort of taking process, it's important to remember that when you're generating a symptom profile, we'll go through the different diagnoses in the DSM criteria in a little bit. But in addition to that, understanding how long they've had these symptoms, did they have any recent stresses? Have they got any have they got any factors that could be impacting or compounding these symptoms? Are there past treatments that they've had? What medications have they tried? What sort of other treatments, for example, psychological treatments that they had, looking at any drug and alcohol sort of symptoms, any history. And these are the history sort of process that you would take in addition to those symptom profile that you would like to generate. Then moving forward, you will then conduct a mental state examination, which we'll go through in a little bit. Following that, I would recommend that everyone has a thorough physical examination. It can range from cardiovascular to GI systems being involved because they can all have either have an impact or could even cause. You could see a lot of patients who've got COPD, who's got panic symptoms, patients who have got panic disorder who are fearing because they've had heart attacks and they're fearing they might have another myocardial infarct. Therefore, getting a sense of what their baseline physical functioning is really important, and also establishing if what their current status is so that they can be prescribed necessary medications. Similarly, appropriate investigations looking at a baseline biochemistry that includes blood counts, liver function test, B12, folate, an ECG to see if they've got a normal QT before starting psychotropics, thyroid function test. As you know, they can either impact or cause mood disturbances or anxiety symptoms, or and as a result of medications could have a thyroid dysfunction. So therefore, getting a baseline testing is important. And depending on the history, I would also recommend that a urine drug screen is conducted if there's symptoms suggestive of substance misuse. And depending on the history, further testings like imaging. Where possible, I think it's really important to obtain collateral history. Often a psychiatric assessment is cross-sectional, and we don't always have longitudinal reviews, and therefore it's important if a family member or a loved one has been present at your assessment, getting their sense of, well, can you tell me about Mr. Joe Bloggs? Like, how do you think he has been? What are your thoughts on what's he's been presenting? Can you tell me a bit about what your observations of his anxiety symptoms are? And I think that's a really good way of comprehensive and finding a comprehensive assessment. So, what are some of these salient features that we look for in anxiety disorders in a mental state examination? Often, patients who present with anxiety symptoms, they may not necessarily be able to articulate their symptoms, but you may be able to observe them in a mental state examination. Uh, they may present as fidgety, agitated, nervous, sweaty. They may be skin picking. They may be playing with their hair. Look for their prosody. Is there a lot of anxious inflections in their tone? Are they describing as they're being worried, panicky, fearful? They could describe it in a whole range of forms. Some patients even report as feeling quite depressed, and they may have depression with anxiety specifiers. So therefore, it's important to explore mood disturbances as well. What's their affect like? Is it fairly congruent? Are they labile because they're so anxious? Is it fairly restricted because they're depressed? We'll go through the thought processes in specific conditions, but think about especially in your older people, older patients, or patients who've got poor concentration or memory lapses. Could there be some sort of cognitive issues at play here and determining whether you should do a cognitive testing like a MOCA and MMSE? So a bit of an overview on anxiety disorders. We've established it's one of the most commonest mental health conditions. It's usually characterized by fear, anxiety, and these behavioral-like disturbances. It can impair functioning and quality of life. And I think early identification and appropriate management in primary healthcare, especially, is very crucial. I would suggest that in those, given it's such a highly prevalent condition, and when there are patients who've got a number of different comorbids, or if the diagnosis isn't as clear, or if they've not responded to first or second line referral treatment options, a referral to specialized systems might be helpful. A general overview of classifying anxiety disorders would be they come in specific phobias, agoraphobia, social anxiety disorder, separation anxiety disorder. But for today's presentation, I'll be focusing on the generalized anxiety disorder, panic disorder, and OCD. Let's talk a bit about generalized anxiety disorder. Often you would get a patient coming in saying that they have had a lot of anxiety, they may have symptoms of panic, and you're then left with a task to sort of then take the next step in terms of assessing them, trying to find a diagnosis, which includes in your history taking that I've mentioned before and the mental state examination. If someone presents with a lot of excessive anxiety and worry, and that's occurring on more days than not for at least 6 months, about a number of activities or events, such as work or school performances, and they find it very difficult to control the worry. That's a very cardinal symptom in GAD. is that they find it extremely hard to sort of control that worry. They're constantly worrying about everything and anything. And it's usually gone on for a period of at least 6 months on most days. Often these symptoms, these anxieties and worries are associated with at least three of these six. In my experience, what I've often seen is people being very restless. They have a lot of sleep disturbances, and they have a lot of difficulty concentrating. They can also talk about a lot of muscle tension, usually in the neck. They get very irritable, and they have a lot of concentration difficulties. Even in this symptom profile, they can overlap with a number of other conditions. Irritability could be part of mania, could be part of depression. It's important to then explore further if they were to present with these symptoms, and therefore understanding if they've got either comorbid conditions or perhaps part of two different conditions. How would you sort of classify the etiology? Well, I would look at it from a biopsychosocial model of care. Biologically, there's about 25% or higher with first degree relatives who've got anxiety disorders might be diagnosed. Comorbid conditions like ADHD, they may have generalized anxiety symptoms, depression increases the episodes, and substance misuse as well. A psychosocial model would be like the chronic stresses around life, financial, anxious personality traits as a young person, frequently worrying, frequently catastrophizing, childhood abuse and trauma. These are things that you could look at in terms of your history to suggest there could be predisposition towards developing a generalized anxiety disorder. Some screening tools, while we could use the K10 in terms of the Kessler's distress scale, but specifically for the GAD or the generalized anxiety disorder, we would look at the generalized anxiety disorder 7-item. It's an extremely easy and useful tool in terms of identifying if they've got screening symptoms of generalized anxiety. There are other tools like the HAMR, which is the Hamilton Anxiety Scale, the Beck's Anxiety Rating Scale, that we could all use at any setting. Panic disorders. Similarly, in your history, you would find patients who may have a whole range of anxiety symptoms. They may present with generalized anxiety, but they may also describe about having a lot of panic. They may not necessarily, I'm feeling panicky. They may say, I'm feeling nervous. I'm feeling like something's about to happen to me. I have this sense of impending doom, like as if something's going to happen to me, or I'm going to die. And they would often describe this constant fear or worrying about having these further panic attacks. They would have at least a month of persistent concerns about having more attacks. Previously, in the diagnosis of DSM-4 and below, they would coupled with agoraphobia. This has now been dropped. Often I've seen patients who would say to me, they're fearful to go out. They're worried about going into crowded spaces. They're worried to go into sort of, private, enclosed spaces because they feel something would happen. So they often coupled with panic disorder, the agoraphobia. And what are the symptoms that they can describe? Well, they can peak within minutes, some of these symptoms: chest pain, palpitations, fear of dying, sweating, tremors, feeling like things are around them are unreal. So it can range from like cardiac to even neurological like symptoms in panic disorders. And again, it's important to understand that are they fairly recurrent? Have they had this repetitively for at least a month? Is it more panic attacks that they have had isolatedly and they've gone away? Or are they so frequent enough that they've gone on for at least a month on more days and they have all these symptoms? And is it fairly crippling for them? In most patients with panic disorder, they are quite recurrent. They feel like they're going to die. It can happen at any time. So there are patients who are described like as if when even at rest, they can feel like they've had a panic episode. So it can happen in the absence of threat. And I'll come to that in a second. Patients who have panic disorder often fear about having recurrent panic attacks. They are constantly worried. I don't want to go out because I worry I will have another panic attack. I might end up fainting. I might end up having an episode. They're so crippling that some patients can even go into a depressive sort of episode. I like to use the flight or fight response in this model. So, as I said, even in the absence of threat, but in the appearance of threat, what happens? The amygdala mostly sort of processes these signals and it sends off a lot of adrenaline and cortisol. And that's normal in sort of, a threat like response. But when it's persistently increased, the cortisol levels and the stress levels increase, it can lead to recurrent episodes of panic attack where your respiration, your heart rate, your energy levels get affected, your vision, you start shaking, you feel clammy, you get dry in your mouth. All these things can happen. This is like the fight or fight sort of response. The OCD diagnosis. Often is present in the presence of obsessions compulsions, or both. You don't have to have both, but they usually are coupled together. They're defined by having both in obsessions. They're persistent in the thoughts and urges or images that they experience. And at some point during the disturbance, they're so intrusive and unwanted that they cause significant anxiety or distress. So these thoughts are fairly repetitive. Patients would talk about, I can't help but stop thinking about them. They're so repetitive, they're intrusive. I don't even think about it. And then they come in and they cause me a lot of anxiety. And what do you do about them? They would often say, I would try to ignore them. I would avoid them. I spend hours not thinking about them. I would avoid certain situation. I would avoid going to a certain corner of the house because that reminds me. Or they start having certain actions, which we call compulsions. And what are these compulsions? They're fairly repetitive behaviors or mental acts that an individual feels driven to perform in response to these obsessions or rules. So they would say, I would need to do these certain activities repetitively. Otherwise, something in order to sort of ensure that they follow these certain um, in order to ensure that they follow a certain rule. And that's why they need to perform this and they need to do this repetitively. And what are they doing this for? Well, it's because they're trying to prevent that anxiety in themselves or prevent a dreaded situation. Often patients would say, if I don't do this, something bad would happen, or there's a sense that says someone could die or something bad could happen to myself. So while most of the time it's there to prevent or alleviate a level of anxiety, it's to prevent a dreaded like situation as well. What are some of these common obsessions? They can be fairly aggressive, sexualized. A lot of patients have talked about religious or scrupulosity. Contamination is probably the number one in my experience. Very somatic, so around a lot of textures, a lot of pain, obsessions around exactness, symmetry, hoarding, and these compulsions like checking, cleaning, repeating things in certain numbers, counting, ordering, these are some of the more common sort of compulsions that you often can see. So it's important to explore them in your history when you see someone in an OCD. What are some of the more common differential diagnoses that you could see in OCD? And while there are a lot of these conditions describe some distinct differences, it often requires you to undertake a much more comprehensive assessment to establish the differences. And in previous DSMs, hoarding disorders, trichotillomania were actually part of the DSMs in terms of OCD disorders. They've now been decoupled and they've put as separate conditions. So for body dysmorphia, um, while both have obsessions and compulsions, they're usually related to physical appearance, but they can be part of a comorbid condition. Similarly, in trichotillomania, they're usually around hair pulling, but they don't have the obsessions around thing or alleviating anxiety. It's more around they hair pull rather than having obsessional sort of qualities around things. Hoarding disorder, it's a lot of people have a lot of difficulties discarding possessions, but it's usually when it's because of an OCD, so they've got a lot of obsession around what their possessions are, and their compulsion is to keep things. Well, then it's an OCD with a specifier of being hoarding disorder. Similarly, in eating disorders, unlike OCD, the focus is of obsessions and compulsions in disorders like anorexia is more on weight and food. Ritualized eating behaviors are associated with eating disorders. Tic disorders, that's another common condition where it can be part of OCD, but it's usually not aimed at neutralizing obsessions, and it may be part of a dual diagnosis. What I think is more important, I'll come to that in a little bit, is that psychosis is ruled out because it can often present like psychosis, and patients can have these delusions which can present like obsessions, and therefore it's important to distinguish between the two of them. Patients can have like a more obsessive compulsive personality disorder. So they'd be describing a much more enduring pattern where they're a lot more perfectionistic, they're rigid. They don't have the level of obsessions or compulsions where they are fairly intense in nature, or they've got that sort of classic alleviating obsessions, compulsions to neutralize the actions. Rather, they would be more perfectionistic and rigid. And again, it requires a much more comprehensive assessment, but these are differential diagnoses to sort of consider. Like I said, with OCD, patients with OCD, I like to look at it as they have more overvalued ideas rather than these fixed, unshakable beliefs like delusions. They're usually ego dystonic. They think they are irrational, but they have no choice but to follow through with him. Psychotic patients are firm and fixed in their beliefs. Specific phobias can be part of this. What are some of the scales you could look at? The Y box is something that I particularly use. There's the self-reporting scale, which is about that is the Yale Brown obsessive compulsive scale. It's about 85 to 88%. It's not a high sensitivity rate, but it helps in a guide in terms of confirming the diagnosis along with the clinical assessment. As I mentioned, there's a high overlapping sort of symptom and diagnostic profile. Often you see patients who've got more OCPD, requires an assessment around that, starts from a more enduring age. Um, OCD itself could start from a much early age. But I also want you to think about if they've got that sort of magical thinking, concreteness, that comes across like an obsessional. Are they having ASD or autism-like features? It's probably worth, if there are other features like language delays, social problems, it may be worth exploring an ASD assessment. I think the other thing to really consider, and I'll come to this in a little bit later in the treatment, is to factor in that when we're looking at treatment, often a reason why an OCD patient's treatment has been perceived as failed is because not enough time or dosages have been adequate in terms of their treatment. So, for example, sertraline in someone who's got severe OCD or moderate to severe, should they have an early response and they've tolerated it without any significant side effects, I would strongly recommend actually firstly increasing the doses to even up to 200 if they've tolerated it, or even 250. Sometimes in patients with OCD, you need to go much higher than normal, and at least giving them about 10 to 12 weeks before considering switching. That's a big reason as to why patients have failed in their treatments. We'll come to the stepwise approach in a little bit. So this is just a slide in terms of differentiating the three conditions. I want you to focus more on the onsets, and I think that's the more key sort of differentiating. And in panic disorders, so for example, they're more sudden, and they're more insidious or gradual in generalized anxiety or OCD. You don't often hear they've suddenly sort of developed. There are a lot of prominent, obviously, physical symptoms in panic disorders, and they may develop these fears of panic attacks, and you get the agoraphobia. In OCD, you may get a lot of these obsessions or compulsive-like behaviors. So often GAD and panic disorder, they can overlap. I would strongly recommend, as I said in the third sentence, my approach is if someone presents with anxiety symptoms and they're looking like they've got generalized anxiety sort of symptoms of a disorder, I would screen for a panic symptoms, panic disorder, and depending on the history, and also phobia. And depending on the history, I would suggest even an exclusion of OCD as well, especially if their history is suggestive of anxiety only. If they were presenting with, say, other mood disturbances, then it's important to sort of screen for depression. And if they're presenting with symptoms of OCD, it's important to exclude psychosis, as I mentioned. Acknowledge the time of onset, how quickly, how insidious, how progressive they were, with any avoidance behaviors. This gives you a bit of an understanding around are they generalized anxiety or panic disorders or an OCD picture? All right. How will we sort of overall approach the management of such patients? Well, I like to use the biopsychosocial model because it's clean, it's easy, and it's easily navigated. And I think it covers all domains. I would recommend using the RANZEP Anxiety Disorders Guidelines for any sort of to refer to. Ensure that it's obviously a shared decision process with your patients, and make sure that all medical sort of organic causes are being ruled out. Let's have a look at this slide. I hope everyone can see it clearly. Look, once you've identified your symptoms, you've established a diagnosis, you've excluded organic causes, you've completed the routine biochemistry, you've taken collateral where possible, I'd like to think that I think the next step, regardless of treatment, is that you advise on good sleep hygiene, a balanced diet, exercise, and obviously address any substance misuse. They can all have an impact on anxiety-like symptoms. Now, I like to divide my management in terms of more generalized anxiety and panic disorders. This does not cover OCD so much, in mild, moderate, and severe. So if someone had more milder symptoms where it wasn't affecting their overall functioning, they had an ability to manage their day-to-day activities, they were not so impacted by not being able to go to work, and they're able to tolerate the symptoms in a certain extent, they're probably much in a more milder spectrum, and they've never had trials or medications. I would probably even recommend the evidence suggests, even in mild depression, the evidence suggests that you can just refer them for cognitive behavioral therapy with a psychologist. In patients who have got a bit more moderate range or who have had failed trials of psychology or for whatever logistical reasons, then you could consider an SSRI. If someone has never had therapy and they're fairly psychologically minded, they don't have any significant comorbid conditions, they could even have cognitive behavioral therapies. For more moderate to severe ends with panic disorders, I would say the recommendation will be to start an SSRI, which is your first line sort of treatment option in regards to treating an anxiety disorder like generalized anxiety who's got panic symptoms as well, or agoraphobia. And then when you're thinking of a failed response, think about, is there something else at play? Could it be diagnoses are incorrect? Could that be confounders? Are they looking at a mood disorder? Do they have ADHD? Is there a personality disorder? And alternatives to the treatments, that's when I would recommend you would need to consider switching, and perhaps maybe at this stage, a referral to psychiatrist might be helpful because it may require a much more comprehensive assessment around things. Let's talk briefly about CBT. It's the gold standard for all mild depressive illnesses that are not trauma-based. It's a structured form of therapy, and it's useful, and it's got gold standard evidence for mild to moderate generalized anxiety and panic disorders as well. Often patients who do not require medications, who've got no major comorbids, you could consider cognitive therapies. I think it's important to find out when your patients come to you, why has it not worked? Have you seen the therapist? How often have you seen them? Is it the type of the therapy being delivered? Was there consistency? Would they have benefited from another form of therapy like trauma-based? Maybe it's because the diagnosis is more trauma-enduring. In OCD, they would combine these exposure response prevention, similarly in panic disorders, which psychologists can use. Patients can also use a lot of self-help or apps on their phone, like CBT iCoach, for example, or Smiling Mind for anxiety management. Now, coming to the more current talk today, which is the pharmacological sort of treatment. This is a bit of an overview. It's not an extensive list. It's just to give us a bit of a guide, sort of consider in terms of what our management options could be. In majority of anxiety disorders, first line, in generalized anxiety, in panic disorders, and even with OCD, you would consider SSRIs as your first line option. The guidelines suggest that when there's a failed response to an SSRI, you would either consider a second SSRI, or depending on the patient's preference, or if there are other factors at play like side effects, you may consider an SNRI or a tricyclic, but they all come with their own side effect-like profile. A contentious area to be discussed is benzodiazepines and what is the role, and we'll come to that in a little bit in regards to, is their role in terms of first line, how long could they be considered for, are they more selective in their usages, and what about more augmentation strategies should you fail with, say, a particular medication? Antipsychotics have often been used. Pregabalin is another one that's often considered as well. But think back about comorbids, previous treatment responses, reasons for failed responses, side effect profiles that needs to be considered. Some of the anxiety disorder SSRIs that are used, so this list is obviously not an exhaustive sort of list. There are probably another 15 or 10 SSRIs that are available. But these are some of the common ones that are often seen. I think the take home, I would say, from this slide is that all SSRIs are effective, as you know, from a number of studies. They've all shown to be effective in all anxiety disorders. It's more a patient tolerance and a case-to-case sort of basis in regards to how effective it can be for individuals. Similarly, you need to take a look at the notes where in some patients who've got very, so like sertraline will be fairly safer in cardiovascular diseases. Fluoxetine has a longer half-life, so therefore you'll be mindful about ensuring there's a bit of a washout before starting out another antidepressant. I have found that in my experience, escitalopram has lesser interactions and a least side effect profile. I'd be very mindful about fluoxamine because of its cytochrome P450 interactions with a lot of antibiotics, antifungals, and even some antipsychotics as well. Paroxetine has got risk of discontinuation. Similarly, with venlafaxine, it's effective in generalized anxiety and panic disorder, but it's probably worth monitoring in regards to, raised blood pressure and also high risk of discontinuation effects as well. Some patients with chronic pain, we often prescribe duloxetine, but it's also useful in anxiety disorders. But I would say first line is always going to be SSRIs. Clomipramine has been shown to be effective in OCD. However, it is not necessarily the first line of treatment purely because of its anticholinergic burden. And there's a very good evidence to say that patients can respond to, even if not first line, if not one SSRI, a second SSRI. In some selected patients, when they've got sleep issues, mirtazapine may be helpful. And think about moclobemide in patients who've got very severe phobias who've not responded to first or second line antidepressants. So, what are the factors to consider? You often will get patients coming to you and say, I haven't really responded to this medication. I want to change and try something else. And I would say it's really important to ensure that they've had adequate trials for at least 4 weeks to see if there's any sort of observable responses. Often the commonest reason as to why a drug has been received as a failure is because they haven't had adequate trials. And the doses have not been optimized. So that may be looked at as well. Think about any sort of drug-to-drug interactions. I would also consider doing a pharmacogenomic study. It's not Medicare funded, but in patients who can afford it and who has had failed trials to numerous antidepressants, it's worth exploring to see are they ultra-rapid metabolizers in certain groups and therefore may need to be considered as to why they're not responding to a particular medication. And obviously consider the more basic things like side effects. What are the side effects that we commonly sort of observe? So in SSRIs, you would often see a lot of gastrointestinal disturbances. Some patient describes a lot of these paradoxical like anxiety symptoms where they feel like they're more anxious at the beginning when they first started, or sometimes the anxiety persists worse than usual. And they feel like I was started the particular medication to alleviate the anxiety, but my anxiety actually got worse. So it's a very rare side effect, but it's possible. Tremors, sexual side effects, often they can persist or they may be short-term side effects. So it's important to explore them with your patients. Think about raised blood pressure because of the noradrenergic agonism with venlafaxine, high risk of discontinuation, especially when you go on high doses like 225 or 300. I think it's important to sort of ensure that you're not abruptly stopping them. In patients who are prescribed tricyclics, it's got a high anticholinergic burden, and it can cause a very distasteful sort of effect for patients, and they feel very turned away by medications. So it's important to be mindful that they're reserved for patients who've only not responded to first line or second line. Also, being mindful that patients who've described anxiety symptoms and developed an anxiety disorder and then prescribed tricyclics, but they've got high suicide risks, maybe because they've got comorbid personality disorders or depression. Being mindful that when you're prescribing to them, that can risk a lot of overdosing as well, and they risk a lot of anticholinergic sort of delirium for them when overdose. Monoamine oxidase inhibitors in the irreversible ones, there's a lot of interaction with thiamine products. Mirtazapine can cause a lot of weight gain or sedation, so being mindful about that. So what is the evidence? Everyone's familiar with the STAR*D trial that came about years ago looking at antidepressants and mood disorders. I had a look at a few studies that have done recently. The Lancet published one in 2019 where they looked at SSRIs for pharmacological treatment in generalized disorders, a systematic review. They didn't find any significant differences between the antidepressants, but it was better than placebo. Pharmacological psychotherapeutic interventions of OCD, a systematic review, SSRIs, CBT, SSRI alone were better than placebo. But when they compared 5 SSRIs, venlafaxine and clomipramine, between them, there was no statistical significance. And I think what that says is, there are not many head-to-head comparison studies to begin with between antidepressants. They're generally obviously a lot more statistically significant in effectiveness compared to a placebo. And I think the studies show that when coupled with, say, psychotherapy or CBT, it's a lot more effective in terms of treatment. I think what that also says is that the guidelines in terms of stepwise approach, individualized tailoring in terms of if patients have failed to respond to a particular medication due to a side effect, depending on their history, that's how I would approach in terms of how you would recommend starting a particular medication for them. There are a lot of non-antidepressants that we can use in patients who've got anxiety disorders. Propranolol is commonly prescribed in panic disorders. Low doses, even between 10 and 20 milligrams. Often patients prescribe this at small doses. But being a beta blocker, it has its own side effects. And I've seen patients who go on to develop depressive sort of symptoms if they're prolonged uses, especially in the older population. So it's something to be careful about. Pregabalin, this is a fairly uh, in a lot of ways a newer agent that's being used for generalized anxiety disorders. There are a lot of cases of patients misusing them, and it can lead to when in high doses, can lead to a lot of euphoric-like symptoms. So being mindful about that in your patients. Quetiapine, off-label use, but risk of metabolic syndrome. Aripiprazole, there's really good evidence in terms of for low dose with augmentation with patients with who are not responding in their primary first-line options in OCD. And benzos, when prescribed judiciously in patients who are not abusing illicit substances, which I will cover in a little bit. So, any special considerations? So, obviously, being mindful about our pregnant population, women who are pregnant, avoid paroxetine is the only one that has got a big no in terms of pregnancy. It causes, as you're aware, persistent pulmonary hypertension. And the general guide, even though it says here sertraline, most antidepressants are fairly safe otherwise than paroxetine. Mother's Safe is a really good guide in terms of contacting for any independent advice. I often use the Women's Pregnancy and Breastfeeding Guideline Medication Guide. It gives you a up-to-date analysis of every medication that's available in terms of trimesters. And I often use that in terms of when I'm prescribing my patients for my perinatal patients. In the elderly, I think if you were prescribing anticholinergic or they are long-term anticholinergics, be mindful about their risk of anticholinergic burden. They can often go into a delirium. They get very badly constipated. Be mindful about benzodiazepines, as you where it can lead to a lot of risk of falls, cognitive issues. And yes, if you've got someone who's got comorbid depression or substance misuse, then you've got to tailor your treatment accordingly. So benzodiazepines, I think this is getting a lot more popular in a lot of ways, where patients are coming asking to be prescribed benzodiazepines for panic or anxiety disorders. And when should they be considered? Well, they work firstly on the GABAergic receptors, where they work as enhancement for the GABAergic receptors. But they've also shown when there is repetitive usage of it, there are times where they can develop cognitive issues. There are times they can develop in the older population, especially falls. They can risk to sort of cognitive impairment. And obviously in the younger population, it can lead to drug dependence, diversion. But what about patients who are willing to engage in, say, a psychologist, who are willing to see GPs or psychiatrists, who are non-drug users, who are willing to sort of commit to, say, a particular frame, and they have found, say, for example, first-line, second-line treatment options like SSRIs have not been helpful. Well, I think there's a place for it. What's the evidence for this? Well, the evidence shows that in some studies, while they didn't have any major head-to-head comparison with antidepressants, like a study done in 2013, they compared tricyclics with benzos. They were both efficacious, but benzos have less side effects and lesser withdrawal effects, but they compared with a very highly side effect sort of profile. Another study in 2018, they compared some antidepressants, so like serotonergic antidepressants. Again, not many, there were a lot of limitations and biases in this study, which was not a very robust study, even though it was a meta-analytical sort of study. However, it sort of suggested to favor benzodiazepines. But I think what my take home from this is, I think there's a place for it. The evidence suggests there is a place for it, but there are caveats that I would apply to this. And I think there are a population of people which we can consider it. I don't think it should be stigmatized as we cannot prescribe benzodiazepines, but it needs to be judicious. It needs to be thoughtful in terms of its prescribing. It probably needs to be timed, and it needs to be under a lot of monitoring. I'm not going to go into this much detail, but there are a lot of novel treatments that have come about in terms of the approaches to anxiety disorders, especially in patients who haven't responded. Psychedelics are now undergoing lots of trials, neurostimulation, TMS, and not in New South Wales, but in other states of Australia. DBS, so deep brain stimulation, is being licensed for OCD, and that's used in patients who are very refractory sort of OCD conditions. Okay, I'll run through a couple of cases of patients in my private practice that were de-identified and have consented for me to be discussed here. And I'm hoping they might be able to perhaps provide a bit more perspective around how an actual presents. So this is a gentleman I saw fairly recently. I'll call him X for discussion purposes. He's 37. He's generally fit and well. He hasn't got any significant medical issues, but about a year ago, he works as a warehouse manager, and he often described himself as a bit of a worried well, had a little panic, a lot of anxiety, like ruminatory sort of thoughts when he was younger, but nothing too pathological, never really identified any significant mental health issues. And he presented with this sort of more gradual, these episodes of panic where they started to get quite profound. He had sought help with his GP and he was prescribed sertraline, which gradually got built up to 200 milligrams. And he was also very psychologically minded. He even engaged in therapy. He completed the This Way Up program and also through an individual psychologist, which he was seeing through telehealth purely because he just couldn't get out of his home. It got so bad to the point where they were so recurrent. He couldn't leave his house. He would have this fear of going out, almost quite agoraphobic. Left his home to the shops and almost had a fainting episode. His K10 was about 24 when I'd seen him, and he was quite disabled in a lot of ways. So I think he had a generalized anxiety disorder with a lot of panic symptoms and a panic disorder with agoraphobia. I would say if you were seeing such patients, you would look at the guidelines in terms of, how would you approach this? As I said before, once you've completed your history and you've undertaken your screening tools, your physical examination, your baseline investigations, you've formulated your diagnosis, you've understood the theories it works. I would say it's important. This patient is already on treatment. It's important to understand, why has he not responded to a treatment? He's engaged in therapy. He's got no substance misuse. He's taken his medications religiously for the last 3 months. They've not responded. And he's on a maximum dose of an SSRI. Given he doesn't have OCD, I would not probably recommend going any higher than that. What will be my next steps? So you could either switch to a second SSRI, which is what the guidelines generally recommends, or through an informed decision-making process, you could consider a selective noradrenaline reuptake inhibitor, given that the patient may prefer for whatever reason. This patient preferred to be on another class because he felt that he had tried a lot of things with the therapy and medications, and he wanted to consider a different group of medications. I eventually had him on venlafaxine, and he significantly improved on 150 milligrams of venlafaxine. That is not to say that if venlafaxine is the necessarily answer in terms of patients presenting. There are a lot of patients who present with with anxiety disorders that respond to a second SSRI. But this is an example of a patient where we approached it from understanding his diagnosis, appreciating, could there have been side effects at play? Could there have been other factors that could be considered? Are there other diagnoses at hand? And it's purely because he has not responded to the treatment. I eventually then swapped him over to another medication. His K10, I think, remarkably improved to a much lower score. He was able to eventually leave his home. While he had not returned back to work, he was able to go out to his workplace a number of times and actually delegate tasks. And he started seeing another psychologist. He hadn't seen one over a year. And my understanding is that his improvement has continued to sort of moving towards the upward trajectory. This is another patient that I've had recently in my private practice. She's a 19-year-old woman who is unemployed, but she's studying IT. And at the time of when I was seeing her, she lives with her parents. She hadn't been able to attend most of her classes. She had prominent obsessions about being contaminated. She spent almost 8 hours a day collectively in the bathroom and mostly on the toilet, where she would have these obsessions around not being fixated around germs when she opened her bowels, and she would have these compulsions to constantly wash her hands. And she would not be able to leave the bathroom. She had hand sanitizers everywhere. She was so preoccupied by it. Eventually, she became so fearful of opening her bowels that she became so constipated. It was extremely disabling and crippling for her. It impacted her overall day to day. Her parents were so distraught. They had asked me for some assistance because they could not send their daughter to university. Her day to day activities were being affected. She's got a Y box of 16, which is relatively high. And at the time of my review, she had already been prescribed 20 milligrams of escitalopram. Her compliance perhaps just prior to being reviewed by myself, was slightly questionable as well. Now, I saw her and I recommended, look, could we work on a? I wanted to make sure that one, we've given her sufficient time at the maximum dose of an antidepressant, which is what I had recommended in my guide before, at least at 20 milligrams for another 6 weeks, which I said at least 12 weeks on a maximum dose. And I recommended that she engaged in an OCD specific psychological based treatment that she started to find in terms of therapy. She did not find any significant improvement with that. Her symptoms were still rather disabling for her. And therefore, on follow up, we decided to swap her over to a second SSRI. A tricyclic was discussed, but however, given that she was very badly constipated, we avoided it. And therefore, sertraline was initiated after it was cross-titrated. Her YBOX score significantly improved from spending 8 hours a day in the bathroom. She only ended up spending 1 hour a day at the time of my follow-up assessment or third follow-up assessment. She had started to re-engage in university and sorry, I've missed a spot. Sorry. I was going to say she improved to a certain extent. However, what she found was that she could not tolerate any higher in terms of the doses of sertraline. And she had still, even though her symptoms had improved, she was still finding that she was not getting enough symptom improvement. And given that she was not able to tolerate higher doses, I augmented her with aripiprazole at 10 milligrams. And she found then the marked improvement. And only then her time spent in the bathroom, which was what was the big change for her from 8 hours a day to just 1 hour in total. And that was a huge sort of alleviation for her because she was able to sort of go back to her day-to-day activities. And then she continued on that dose regime and she's continued to engage in therapy as well. Thank you.
Wow, thank you so much, Dr. Sandhu, for that very comprehensive presentation. I certainly learned a lot myself. Um, Thank you all for joining. If you've joined before, you know that this QR code will take you to our feedback form. Please take this opportunity to scan the QR code and fill out that form for RAC GP compliance. If you do require a certificate, please fill this form out. And please contact me if you would like a certificate tonight or tomorrow. I will be going on leave on Thursday, from Thursday onwards. So it would be great to get that to you before I am off. Dr. Sandhu, that was an amazing presentation. And because you are new to our clinic and have availability, before we dive into the Q&A, did you want to just tell everyone a bit about yourself?
Sure. Yeah, thanks. So I'm a general adult psychiatrist, and I've undertaken additional training in the area of consultation liaison psychiatry, which is essentially the interface between medicine and psychiatry. I have a special interest in working with patients who've got chronic pain, perinatal disorders, neuropsychiatry. I see all patients ages between the 18 and 70, and I see all general adult disorders that includes mood disorders. My area of interest would be refractory OCD, patients who have got a lot of challenges in terms of management of their OCD. And I see patients who've got personality, psychosis, and mood disorders. My approach is very much a holistic sort of approach where I combine a lot of psychological and pharmacological principles in my practice. As Namita mentioned, I've just started. I'm accepting new referrals. I've got low waiting periods at this stage, and I am offering both face-to-face and telehealth. For telehealth, at this stage, I'm only offering them as follow-ups. All new patients will be seen as a face-to-face consult at the beginning. Thank you.
Amazing. Dr. Sandhu, we'll just dive into the Q&A now. Dr. Wu has asked, or rather mentioned, now every female in her 40s thinks that anxiety is due to menopause. What are your thoughts around this?
Yeah, I think that's a really good question. It's important to rule out. So often you see perimenopausal or menopausal related symptoms that are, either part of a comorbid, and I like to put it as if they are, again, timeline in terms of symptoms. So when did they sort of present with their symptoms? Are they coinciding with menopausal symptoms? Hot flushes, irritability, mood swings, they can all part of the sort of, the diagnosis like that. I would sort of strongly recommend, there's good evidence to suggest firstly SSRIs do respond to anxiety disorders in patients with menopause, but I think trying to disentangle based on your history, completing a hormonal studies, a referral to an endocrinologist might be really helpful to sort of establish the differences between the two. But in patients who are difficult to sort of establish, refer to a psychiatrist, but considering an SSRI in these sort of situations is helpful.
Fantastic. Next question by Dr. Wu is, can you explain how to differentiate stimming from tics clinically?
Yeah, so tics are generally these sort of repetitive, stereotypical sort of involuntary movements. And, often they don't. So if I were to sort of characterize it, as I mentioned, in terms of OCD, which is one of the most commonest overlapping like condition, I would say that they don't have that necessarily obsessional sort of thoughts where they have these intrusive thoughts to alleviate an anxiety. Rather, they hairpool out of purely from non-obsessional related anxiety. So there's a difference between the two. Also remembering they can be part of a comorbid sort of condition. So people can have tic disorders, but at the same time have OCD-like behavior as well.
Perfect. Next question is from Dr. Walker. Any SSRIs/SNRIs have more evidence than others for GAD?
Look, I think the evidence is fairly good for all antidepressants in terms, as I mentioned, there are not many head-to-head studies. Um, Often in my experience, more than anything, rather than the evidence as I've shown you in the more recent papers, there's no significant evidence for one over the other. But from my experience, I've often found, again, depending on the history, what are their symptom profile, if they have had previous responses, I would consider my first line evidence in patients who are, let's say, they've often said to you, I've often been naive or sensitive to medications, and I'm very concerned about starting, and their symptoms are far more milder. I would often start an escitalopram as my first line, and then I would move up to a second line. My preference of choice for an SNRI is depending if they've got no other comorbids like chronic pain, I would consider starting them on a venlafaxine dose regime, and that'll be my sort of suggestions. But as the evidence sort of shows, there is no real head-to-head comparison, and they're all generally fairly effective.
Good to know. Next question is from Dr. Wu. Which would you start with first, escitalopram or sertraline?
Certainly. Yeah.
Which dose
Uh,
to start and maximum dose?
Sure. So my personal experience is that I would start patients on escitalopram at 5 to 10 milligrams, depending on body size, depending on if they've had previous medications, and monitor them for side effects, and gradually build that up between 2 to 4 weeks to about 20 milligrams, depending on tolerance. I would monitor them firstly at 10 milligrams to see if they've been able to establish that at a dose response or a therapeutic response. I often find a lot of patients tell me that with sertraline, and again, this is a very case to case sort of basis, that I've often found that patients tell me with sertraline, they get a lot of GI disturbances and they also describe sexual side effects with sertraline. So that's just my preference. But again, the evidence is fairly good for all medications.
Perfect. Another question from Dr. Wu. What is your preferred antipsychotic for augmentation?
Again, it will depend on what are we augmenting with. So if it's augmentation with OCD, which is one of the most commonest augmentation strategies, like my patient that I described earlier in the case scenario, I augmented her with aripiprazole. It's a very good, because it's got a partial dopamine agonism. I think it's got that sort of ability to sort of augment in terms of when someone has, say, responded partially to an SSRI or a second SSRI and they're unable to sort of tolerate higher doses. I have augmented with risperidone or quetiapine. Often I find with risperidone, the concern is that they raise their prolactin levels. Therefore, I need to be mindful about that. It's important to look at when you prescribe aripiprazole, obviously, even though they don't have the metabolic issues, they can have a high risk of akathisia. So being mindful about them developing a lot of restlessness.
Thank you for that, Dr. Sandhu. Next question
Uh,
from Dr.
Namita,
Wu.
you've gone frozen, but I can.
am I, can you hear me, Dr. Sandhu? Apologies if that's, I'm frozen for everyone. The next question is from Dr. Wu. Is this escitalopram effective in OCD?
I think it can be. Often my preference with OCD has been some of the more activating or medications like fluvoxamine or fluoxetine. I think they can be effective. Like the patient that I prescribed on sertraline, and I would have probably gone to a much higher doses. Often I would go, say if I've got them on escitalopram, I'll go to 25 or 30 milligrams to ensure that, I've been able to establish a treatment response. Um, I think it's very important to follow that stepwise approach before you can move to another medication. As I mentioned, one of the commonest reasons as to why a failure in medication is being perceived, because in OCD, it requires that prolonged treatment response and it requires a much higher than usual at times.
Next question is from Dr. Walker. Lots of CBD plus minus THC prescriptions being written for patients with anxiety. Evidence, your opinion? Question mark.
I have fairly limited evidence experience in this area, and in my opinion, I think the evidence is sketchy at best. Um, I think the trouble with a lot of medicinal cannabis that I have is that I'm seeing it being prescribed and so rampantly that one, it has a high risk of actually worsening the anxiety when there's a coming off sort of effect. Two, they require a lot of high doses. Three, I'm concerned about the drug-to-drug interaction with the more conventional medications. I do think a lot of patients talk about that subjective sort of feeling of alleviation of anxiety. The trouble is the regulatory side of things and how often, and I guess the ongoing sort of prescription for that.
Fantastic. So, next question is from an anonymous attendee. Is there any role for new genetic testing to see who will respond to which SSRI slash SNRI?
Uh, yes, so I think pharmacogenomics testing can be helpful. Um, However, from my experience, I think the results have been a very mixed sort of bag. Um, I think if someone has had a failure to number of medications, but I would not necessarily recommend that off the bat for someone who's saying they're going to respond to an SSRI and SNRI. I don't think the evidence is there for that. I think the evidence is more for patients who have not responded to a certain number of medications for whatever reason, and therefore then you can go back and consider genetic testing.
To know. Um, Dr. Wu has asked if you see work cover patients or ADHD patients.
I don't see ADHD patients, but I'm not seeing work cover at the moment, but it's a space that I'm looking to explore, hopefully down the track.
Fantastic. Dr. Ramos has just asked if you do telehealth, if you see patients via telehealth.
Yes, I'm happy to see patients via telehealth as a follow-up, but all initial consults will have to be a face-to-face appointment.
Fantastic. Dr. Dwyer has asked, in patients who use benzodiazepines periodically, perhaps once a week or month, how long do you think this is appropriate to continue?
I've seen patients, even as recently, who's been on 25 years of being on clonazepam and alprazolam. Now, unfortunately, it was started years ago, and I'm mindful that they have been on that medication for that long, and I don't want to risk a withdrawal effect. I don't want them to risk a seizure effect. I don't want them to feel like they're going to struggle with their panic attacks. These are very selected sort of individuals, and I don't think at this stage off the bat as a first line, that should be something that I would consider. That being said, if patients are fairly psychologically minded, they're willing to engage in therapy, they don't have a drug and alcohol history, they're willing to offer you a urine drug stream at random, they're willing to work with you in regards to, say, seeing you at a certain time frame, I think that's fairly reasonable in terms of prescribing a benzodiazepine. I think there is a place for it for anyone who has had failed responses to, say, SSRIs, and they are doing all of the above. They're not drug using. They've got the ability to conform to a structured norm. Their ability to engage with health services. I think there's a role for it. Yes, in patients, say, for example, who are have got more adjustment disorders. They've had recent losses. They've had milder versions of anxiety, but they want to work with a psychologist. Perhaps that's where you could consider as a bridging sort of effect, where you could prescribe them a benzodiazepine initially to see whether they will have that initial response with it, and then work towards considering just moving on with psychological based treatment. So it's a very case to case sort of scenario. I don't think that there is a rule to say that we should exclude it entirely, but I think there's a place for it. There needs to be certain caveats in place.
Planned approach. Um, Next question is from an anonymous attendee. Is agomelatine also a reasonable first-line choice?
Look, I think agomelatine has got a place in terms of more sleep disturbances because of its effect on the melatonin levels. There is a place in terms of sedation and sleep. I don't necessarily find that a relatively useful first-line agent for anxiety disorders, but it may be helpful in terms of comorbid depression who've got more sleep-related disturbances.
Mm, Another question from Dr. Dwyer. Any medication preferences for patients with anxiety who have a past history of trauma?
I don't think there's a particular medication who I would suggest that is more effective for trauma. I think when you're looking at trauma, I think you're looking at what will be the first line treatment options, in my opinion, is going to be therapy, specifically more trauma or dynamic oriented therapy. And depending on their comorbids, if they've got an anxiety disorder that is more generalized or panic disorders, then you may consider an SSRI accordingly. But there's no one particular medication that's more helpful in trauma.
Good to know. Um, you'll need to help me with this one, Dr. Sandhu. I probably will not
Yeah.
be able to pronounce
What
this
is your Sure. What
medication.
is your take on percozine ulactil? It's a fairly old drug that's not very much used anymore.
Okay, that was a quick one. Next one is from Dr. Barry. Can you use two SSRIs same time for one patient with anxiety?
I would not recommend it purely because it could become very serotonergic. I think the guide is that you need to switch your medications and also being mindful that when two SSRIs at very high doses, it's not common, but if, say, for example, they were on opiates or they took a low dose of, say, tricyclics, you could be risking serotonin syndrome and patients could go to hospital. And that's effective for patients either. So two SSRIs are not going to be just the way the drug mechanism works. It's not likely to have a much more potentiated effect. You'll need to look at cross titrating or looking at switching over to another medication.
Dr. Walker has just said thank you for the talk and for the answers to all of the questions. Thank you, Dr. Walker, for
You're
joining.
welcome.
Um, Dr. Tezjan has asked, can you advise on the best antidepressant in the elderly, either for depression or anxiety?
Look, I think I've often gone to mirtazapine in the elderly purely because I find that, and again, there are lots of caveats to this. So, for example, you've got someone who's got a high risk of falls. You've got someone who's got diabetes. Also, remembering antidepressants can affect the insulin resistance, and it also can increase your blood sugar levels. So, in the elderly, I'm being mindful. Also, remembering that in the elderly, SSRIs can lead to low sodium levels. So, I'm mindful about the elderly that if they were presenting with a very severe anxiety disorder, then perhaps considering an SSRI or an SNRI. However, I'm often using low-dose mirtazapine as a first-line agent purely because it allows them to have that sort of sleep effect. It's fairly safe. And unless they've got significant metabolic issues, I think that's probably what my first-line option would be.
Good to know. Next question is from Dr. Barry. Is there any role of prazosin?
Yeah, I mean, I think prazosin is much more useful in terms of PTSD-related nightmares. All PTSD-related drugs, the evidence is sketchy. So prazosin, clonidine, even mirtazapine. Mirtazapine has got some evidence. It's a very mixed bag sort of results. Often it's very case to case. and sometimes it requires a lot of high doses to be prescribed. And I'm mindful about if it'll drop the blood pressure being an antihypertensive. So I think it's important to be careful when you're prescribing that. I've had patients who tell me that they've had more a trauma-related or PTSD-related response, and they find that prazosin can be helpful. But I think it's again a case-to-case sort of scenario.
Next question is from Dr. Hanbury. What about using escitalopram and mirtazapine together?
I think there's a option for doing that. I would not probably start it together at the same time. I think it won't allow you to establish treatment effects. It won't allow you to establish an understanding around which medication has been effective, which medication has caused side effects, and I also don't know if it's necessary. But that being said, I think there's a role when you've started an SSRI, and assumingly they've responded to a certain dose, but they've only gotten a partial response, and for whatever reason they're not willing to engage in therapy, or they've not found therapy helpful. Perhaps maybe if they're looking to alleviate, say, symptoms like sleep or appetite changes, then you could. But being mindful that whenever there are two antidepressants, even at two different categories, some patients can find it very hard to sort of tolerate. They may get a lot of serotonergic side effects. Mirtazapine is not very serotonergic. It's a very selective serotonergic. So therefore, I'm not too concerned about the serotonin syndrome side of things. But yes, there is a role for it. I would just not recommend starting it together. I think there's a role for perhaps starting the escitalopram first, and then gradually over time, again, going back to principles like there's a good treatment response. You've observed the patient. Have they considered therapy? What are the other reasons they're not responding? Treatment for other confounders like diagnosis. And if it's purely to alleviate other symptoms, maybe there's a trauma response, maybe there's sleep factors at play here. Mirtazapine is a reasonable option to consider after that.
Fantastic. Well, that was the final question that's come through the Q&A box. Thank you again, Dr. Sandhu. Everyone, if you have not had the chance yet, please scan the QR code on the screen to fill out the feedback form. Your feedback is greatly appreciated. Like I did mention earlier, my last day in the office is Thursday. So if you would like a certificate, please fill out the form and send me an email tonight or tomorrow, and I will get that certificate through to you before I am off. Um, if there are no further questions, Dr. Magali has said thank you. Dr. Adrian has said thank you. We might end the session there. Thank you, everyone, for joining. Thank you again, Dr. Sandhu. And Dr. Sandhu is again accepting patients at Ramsay Clinic, Wentworthville. He has appointments within the week and is offering telehealth for patients after the initial consultation. You're more than welcome to refer to him. Thank you, everyone. Have a lovely night. I will be ending the session here.
Thank you, everyone, for joining.